I'm so glad you're here. This is a replay of a live training I did inside the OTs for Pelvic Health Facebook group with Lindsay Vestal, and I wanted to make sure that everyone gets access to it. Pelvic health is such an incredibly fulfilling specialty, and it's growing so much. I've been training OTs since 2018, and my goal is to have over 10,000 OTs trained by the year 2030. I'm so glad you're here learning about this specialty. I hope that you can join us in the OTs for Pelvic Health Facebook group with me, Lindsay Vestal. I will link to the group below in the show notes and description. Thank you so much. All right, everybody, welcome to OT Empower Hour. This is a special presentation. I am so excited to welcome Tara Weigall-Wersching, who has been a longtime member and incredible part of our community. Got to meet her in person just actually, we've met a few times, but OTs and Pelvic Health Summit a couple weeks ago. I think we met at last year's Arizona conference for the first time in person. Is that right? Am I remembering that correctly?
We met at the Western conference in Las Vegas. Was the first time.
We love presenting, Tara, don't we?
Yes, we do. Exactly. You're all over. Yes.
You are too, and I just love it. So I want to say that today's presentation, which is called The Urinary System with Pelvic Floor Dysfunction, is actually a 4-hour lab that Tara is giving next weekend at our Arizona conference. And so today's presentation is a 30-minute excerpt from that. If you are available next weekend to come down to Phoenix and hear the full presentation, it's going to be well worth it. I'm super excited because I'm going to be speaking about constipation. Doug, my husband, is going to be there, and he's going to be talking about authentic marketing for introverted OTs. I mean, it's going to be a fabulous conference. It always is. Last year was amazing. It was my first time speaking in person after moving from France back to the United States. And so I'm really excited to be back. And Tara, this is going to be fantastic. Thank you I'm sure it was a challenge to take a 30-minute excerpt from a 4-hour lab. We're grateful you did it. And thank you for being here today.
Oh, well, thank you so much for having me and allowing me to present today. I greatly appreciate it, Lindsay.
Oh, such a pleasure. Tara, will you give us just a little, 2-second bio of you, just so we have a little bit of your appreciation of your background before we get started?
Yes, I've been a therapist for 36 years now, and in August, and so it's just been a wonderful profession for me, and I love it. I actually the snippet for getting me into pelvic floor dysfunction and specifically urinary incontinence treatment was back in 1995 when I was with a company called Sundance Rehabilitation Agency and Accelerated Care Plus. And so I ran the pilot project here in Phoenix, and I was a program manager for the Western United States. And I taught occupational therapists I had from Mississippi over to Hawaii in the pelvic floor dysfunction and incontinence. It was a 4-hour continuing ed course and with a lab. And so that's kind of where I've got this idea of I will give 2-hour lecture, 2-hour lab at the state conference in the same direction that I used to do that back in the day. And so this is in 1995 that I started that. So I just want to share that no person should be incontinent of either fecal or urinary incontinence or matter. And so I'm just excited and to be able to be among the pelvic floor therapists and just continue to grow.
I love that. It was such an honor. We're so excited you're here. Yeah. Let's kick it off. I can't wait to hear your lesson today.
All right. Well, thank you. So yes, I will be focusing on the urinary system and pelvic floor dysfunction today. And I really like this picture because we are looking through the OT lens, and it's occupation-centered anatomy. And I don't think that we get this in school. So we don't get anything about bladder function and bladder anatomy and also the urinary tract system. So that's what I'm going to do, the basis of understanding and that hierarchy of the urinary tract system which follows as such the ureters, the bladder, which is actually the detrusor. It's a muscle. People don't understand that it's actually a muscle. They just think it's an organ, the bladder. And then the trigone, and then going into the internal or the involuntary sphincter, the external voluntary sphincter, and then the pelvic floor musculature. So I'm going to go straight to the ureters. And as we can see here, the ureters drain from the kidneys down into the bladder. And that bladder, I want you to see where it's situated in this diagram. I really do like this picture because it demonstrates how much that bladder is protected by the pubic bone, but how unsafe it can also be with a pelvic fracture. And so that's something that's key. And also just knowing that the ureters are going to drain the urine straight from the kidneys, and they influence the flow of the urine. This is a little bit of a busy slide, but again, the bladder is a muscle, and it's called the detrusor. The detrusor is a smooth muscle of the bladder wall. It's going to relax to allow the bladder to fill, contracts to eliminate urine. And then I'm going to really hone in a lot on the trigone. The trigone is the very light tissue that you see. As an example in this, I don't know if you can see my cursor, but as I follow that, it's a white cursor here, so I don't know whether you can see that. But the trigone is a triangular shaped tissue of the bladder. And in 1995, I was actually able to go to a pelvic floor dissection course in St. Augustine, Florida, which was absolutely fascinating. And so when we opened up the bladder, the trigone was so different from the bladder, the smooth muscle of the bladder wall itself. It is different tissue, and it applies traction to the ureteral openings. And these are little dark arrows here, the ureteral openings here. And that's where the ureter comes down, and then the outlet. And so inside that bladder, and the trigone is right below that ureteral openings, and it senses toxins in our body. So I'm really going to be going into what bladder irritants are and what it does to our body as well today. So going into internal and external orifices, I'm going to do a little bit of this. It's a 2 outlet valve system. The internal sphincter is a ring around the actual muscle that holds the neck of the bladder in place, and it opens and shuts automatically without you thinking about it. Now, the other is, as I mentioned a little bit before, the external sphincter. It keeps urine in the bladder, controlled by the pudendal nerve, which I'll talk about in a little bit, which is controlled by the voluntary nervous system, which is under your control. So a recap, the internal sphincter opens and shuts automatically without you thinking about it. And the external sphincter, we have voluntary control over. And then the nerve supply is through the sacral nerve plexus and the pudendal nerve, which innervates the pelvic floor musculature, can become pinched when sitting for long periods of time. And I have done most of my profession of 25 years of 36 in long-term care. And so I want to mention that that pudendal nerve can get pinched. When people are sitting on improper cushions or anything like that, it can become pinched and can cause that pelvic floor musculature to become weakened or just not get the right information sent to the bladder. And so you have to have the right dynamics between the bladder and the pelvic floor communicating. And those folks that were in long-term care just couldn't, and we'd have to make sure they were on Roho cushions or some type of a preventative cushion. And they were incontinent. So some of them I would pick up to be trained to become continent. So here is a nice illustration of the pudendal nerve, which is in yellow. That's represented in yellow, along with the red is the artery, the blood flow. The pelvic floor musculature is highly rich in blood flow, as well as innervation of the pudendal nerve. So just reiterating a little bit about the stretch receptors located in the walls of the bladder, become very active when the bladder is half full, send signals to the pelvic nerves and spinal cord. The micturition reflex signal is sent back to the bladder. And then the detrusor contracts, increasing the pressure in the bladder, making you want to urinate. You can override this sensation, as I talked about just a bit ago, because the external sphincter is under voluntary control, and you will not void until you decide to relax the detrusor. So here's a nice picture of the micturition reflex that it is controlled by higher centers of cortical control. Tells you when you need to empty your bladder, and that happens an average of 4 to 8 times in a 24-hour period of time. The average bladder capacity is anywhere from 300 to 600 milliliters for approximately 5-hour period of time. I like to think of the urinary system as a sensory motor system. We have to have the brain sends a series of messages to the body to pass urine, to the detrusor muscle to contract and squeeze urine out into the urethra, to your sphincter telling it to relax, to your pelvic floor telling it to relax and allow the sphincter to open. And then when the bladder is empty, the sphincter relaxes again, or closes, excuse me. The bladder floor tightens and the detrusor relaxes, allowing bladder to fill and expand again. So why I call it a sensory motor system really is the therapists that I educate and staff is that if we look at my hands and the bladder is, I'm the bladder right now. And so if we have sensory fibers all over the bladder. And so we need to get, it feels the proper filling of urine, and then we get it to contract and we get the motor output. So it's really sensory input, motor output that we as occupational therapists hear all the time. And the 3 areas that must work properly are going to include the sensors that are going to tell the bladder to empty, to fill, the sphincter, and the nerves that communicate with the brain and spinal cord. Excuse me. When the sensors must tell the bladder to empty or fill, and they're not working properly, it actually becomes something that's more of stress incontinence. And the sphincter, if damaged, or the pelvic floor, the top one, sensors, would be urge incontinence, type incontinence. And if damage to the pelvic floor is damaged, the sphincter will allow urine out, which is called stress incontinence. The nerves that communicate with the brain and spinal cord, if damaged, the signals won't work properly, and there may be a mixture of both urge and stress incontinence. I want to let you know that the older females actually have more mixed incontinence, again, which is your combination of urge and stress at the same time. So they're having to cope with a lot as they are aging, more due to hormonal imbalances. And that's where estradiol comes in, which is a whole nother topic. But I wanted to provide a picture of female pelvic floor anatomy, normal anatomy by Netter. And I always tell the students that these 10 areas are the ones that are most important. And then going on to the male pelvic floor anatomy, we can definitely see there is a difference, but to also know those 10 structures as well as you would the female anatomy. So I wanted to tell you that I was going to reiterate the bladder irritants and their impact. There are a lot of irritants to the bladder, which the trigone senses, namely alcohol, caffeine, carbonated drinks and sparkling water, artificial sweeteners, chocolate, chili peppers, foods that are high in spice, sugar, or acid, especially citrus fruits, heart and blood pressure medications, sedatives, and muscle relaxants, as well as large doses of vitamin C. What I tell my clients, if they really want some iced tea, say they might be iced tea lovers. Now, we here in the beautiful Arizona sunlight, we have an abundance. And so it's also hot. And those of you who came to our event in August. So this was, if you put out sun tea and you make sun tea, the UV rays actually cuts out the tannic acid in the tea. So tannic acid is not a bladder, it is a bladder irritant, but the UV rays takes it out. So you can drink as much iced tea, sun tea as you would like. And so they say, oh, I'm overjoyed, and they try that, and it makes a huge difference to them. And I say, go in the winter, because we still have an abundance of sunshine, and heat your tea up. So they really are looking forward to maybe 1 cup of coffee, but if they're strictly on some bladder irritant, anti-irritants, then we want to help control their urine as well. Then they can go on to doing something different. Now, are you drinking enough water? And the essence, I call it the essence of life. The drinking of water is so important. I want to throw this picture up because this is something that we all need to really look and study. The light yellow is where we should be. Almost clear to light yellow is where your urine color should be. Where it's a little bit in the yellow or the amber, we're getting into a little darkness. And then when you get into brown or red, you're definitely into a serious situation. And so we need to drink enough water, and adults usually don't. And what can lead to as well is urinary tract infections. Infections can irritate your bladder, causing you to have a strong urge to urinate, and sometimes also cause incontinence. Constipation, this is one area that I'm going to mention. The rectum is located near the bladder and shares many of the same nerves. So any hard compacted stool in the rectum can cause these nerves to be overactive, increase urinary frequency. So looking at the pelvic floor muscles, what 5 important roles do they play? Well, they support the organs. There's a sphincteric function, there's core support, circulation, and sexual function. So what actually happens when there is pelvic floor dysfunction? You can only imagine that all of these 5 areas can become impacted. And this can also cause different types of incontinence. And so I really liked this picture because it demonstrates the pressure on the bladder, the detrusor, again, sending sensory information in, that the motor output is going to be different, and stress incontinence is due to increased abdominal pressure. Under stress, we have weak pelvic floor muscles. And under urge incontinence, it's due to involuntary contraction of the bladder muscles. Excuse me, and overflow incontinence is really due to blockage of the urethra. That might be something where it's prostatic hyperplasia. Neurogenic incontinence is due to disrupted function of the nervous system. So incontinence can affect daily occupations. We know as occupational therapists that Fecal and urinary incontinence impacts the lives of so many individuals, and it affects their ADLs, their IADLs, and their sexual function. So what can be done? What we do as occupational therapists, we do ADL training, bladder training, and urge inhibition training, habit training, prompted voiding. And I just wanted to throw this down at the bottom box here about treatment can reduce falls, because these adults or geriatric clientele, they actually can slip in their urine and people think that it's on the way to the bathroom. No, they fall on their way back to the bed because they're urinating on the floor as they go to the bathroom from the bed. And what they do is they slip in it coming back, and they can fall. And excuse me, and that's where a lot of the hip fractures take place, is going back to bed at night. So pelvic muscle dysfunction treatment. So pelvic muscle PMEs is usually referred to as PMEs. Biofeedback assisted therapy is advanced trainings necessary. Electrotherapy assisted is also advanced training. But there are some that are evidence-based that are related therapeutic exercises, which are your adductor therapy exercises, abductor or the obturator internus, TheraX, the gluteal exercises, transverse abdominis exercises, and the pelvic floor activation. So pelvic floor exercises are keeping everything in balance, and it's a non-invasive treatment option. Talking about Kegels as well, the accessory muscle strengthening and the diaphragmatic breathing is very critical to helping retrain the bladder, as well as and have that nice sensory motor component again back with the bladder and communicating with the pelvic floor muscles. So I went through this very quickly. We are the key to hope through education and treatment. And I just want to let you know that I really have a love for this and for teaching. And I think that it is so, should be impassioned in all of us to make sure that we educate our clients and their family members, and even physicians and nurses, nursing aides, that there is a part of the bladder that is this trigone that senses bladder irritants. And it's just so critical that they have an understanding of that. I want to thank all of you for your time, and my references are listed. And I also have some wonderful resources. I'm going to point out first that there's OT Pioneers in Pelvic Health by Miss Lindsay Vestal. And then at the top there is Herman and Wallace Pelvic Rehabilitation Institute, the International Continence Society, and the National Association for Continence. And then there is Phoenix Core Solutions by Janet Hume, who is a physical therapist. So thank you again for your time. And I don't know if we have time for questions, but we'll see.
No, that was fantastic. Thank you so much. What a comprehensive, and I know that if we had the pleasure of attending your 4-hour lab, it would be even more comprehensive, but you really jam-packed it with such rich information. So we're so grateful for that. We do have Rebecca joining us, and she says, yes, I'm not going to say this right. Yes, sensory and motor is what I'm trying to say. Very OT. She loved that and was agreeing with you.
Great.
I'd love to ask if anybody has any questions for Tara. We will open up the floor now for that. And also she's a very active member of our group. So if you're watching this on replay, by all means, throw your question in. Let us know where you're joining us from. Rebecca, are you in Asheville? Are you joining us from North Carolina today? We did get a question coming in from Emily. She says, thank you so much, Tara. Have you seen that bladder irritants impact stress incontinence, or are they primarily a factor in urge incontinence?
I have witnessed it also in stress incontinence, usually in mixed. So that's why I'm combining that with urge, because of the sensory information coming in, and the irritation that it can cause to the detrusor, which can be more activating to that detrusor and the trigone area.
Perfect. And then Rebecca's got a question, which she says, are there continence hotlines patients can call with ICS, for example?
That Rebecca, that is an excellent question. There is not, but I'm trying to get as active as I can in the International Continence Society, but there is a nurse that has her own society, and there is a hotline, and I will try to get that information to you. She lives, I think, in Australia.
There's still so much work to be done, isn't there?
Oh, yes. Yes.
Well, every single one of us in this group are changing that every day that we show up and share our knowledge and share our knowledge with clients and each other. So you're such a big part of that, Tara. Thank you so much. Rebecca says thank you. Emily joining us says thank you. This was fantastic. If anyone has any other questions, throw them in the comments. I am so excited that you could be with us today, and your lab is going to be phenomenal. So thanks for all the work that you do, Tara.
Oh, well, thank you, Lindsay. All right. Thank you, everyone.